So pretty important subject. And the feedback that I got is this is like one of the most important. You're gonna deal with these things every day, and this is, essentially electrolytes. And we're gonna talk about every electrolyte one by one, and every condition about every electrolyte one by one, and how to replete and how to treat every problem with every electrolyte. Okay, it's very simple, but it's very overwhelming because when you come here, you don't know exactly what to do. You will get a patient who has hyperkalemia, hypokalemia, hypercalcemia. If you've never dealt with it in your life, even if you have, maybe the protocols are different, you don't know exactly what to do. So I will make it as simple as possible to tell you exactly what you need to do as an intern, or even as a resident. What are the steps expected of you, or what do you need to do to treat each condition, okay? So let's start with potassium. It's the most important, the most common, and somehow the simplest, okay? But you just need to follow some sort of algorithm, okay? So what's the normal potassium levels in your mind? Do you know?
5 to 5.
3.5 to 5. I usually like to think of it as 3.5 to 5.3. But obviously 5, once it gets 5, it will flag up and it means hyperkalemia. But, above 5.3 you start thinking of, it becoming severe hyperkalemia maybe. Okay? So let's start with hyperkalemia. So hyperkalemia, what's nice about hyperkalemia is that it is well regulated. It means that there is a well regulated algorithm that you can follow, and if you follow it, usually you'll be fine. Okay? So when you have a patient who's hyperkalemic, let's say the potassium is 5.6, okay? What is the first thing, the initial step that you need to do? Because this will help you in the management of hyperkalemia.
ECG.
EKG, exactly. So you have to do an EKG. And you have to look in the EKG of signs of hyperkalemia, okay? The signs of hyperkalemia you can see on the EKG is first a hyperacute T wave, okay? That's number one. Number two, you can see a widened QRS complex, okay? And then if it gets wide enough, it starts widening, and then the QRS complexes will start marching with each other, you will get something called a sine wave. That's severe hyperkalemia. And then finally, you get VTAC essentially. Okay, and VFib perhaps later on. But this is the progression of hyperkalemia in terms of what exactly happens. Okay, so you do the EKG, and then you're gonna ask yourself, is there changes? So either there's no changes on the EKG, the patient is hyperkalemic, but there's no changes, or yes, there are changes, which means any of those changes, a hyperacute T wave, a prolonged QRS, especially if the changes are different from baseline changes, okay? So if there's no changes, we'll go to the next step. But if there are changes, what's that gonna change? Why do I care if there is EKG changes? Any idea?
Protect the heart.
You want to protect the heart, right? So if you have hyperkalemia, what happens is that you are at high risk of getting all these, of developing VTAC essentially. And what you want to do is you want to stabilize the cardiomyocyte membranes. And how do you do that?
Or give calcium.
Calcium. So you have to give calcium, okay? So this is always a question. What sort of calcium should I give? You're going to ask your senior, you're not going to know. Any calcium, as long as you give it IV, okay? So you can give calcium gluconate. You can give calcium acetate. Or you can give, what else? Calcium chloride. So anything, essentially. And you usually, how much you give? You give 2 grams IV of calcium, okay? And this will ensure that you are protecting the heart, okay? So far so simple, right? You do the EKG, then you give calcium. So this is the first thing to do is essentially to give calcium. Let make this smaller. Now, after you give calcium, then you're gonna treat the hyperkalemia. So remember, so far we're not even thinking about what caused the hyperkalemia. We're thinking about treating it right away, and then you start thinking about the causes. We'll talk about the causes after the treatment, but let's treat it first, because this is the most important step. You need to do something quickly, because otherwise it will progress to VTAC, okay? Especially if it's very high. Okay, so there's two major ways of treating hyperkalemia. There is a method where you shift the potassium into the cells quickly, and this happens very fast. And there's a method that depletes the potassium from the body, and this is slow, as you expect. Okay, so let's start with the first method. So the first method, you're gonna shift the potassium into the cells. Okay, so number one is shift potassium into cells, and we said this is fast. Okay, so what are the options here? So number one, you've got insulin. Perfect. So you've got insulin, and you can't give insulin alone. You have to give it with glucose or dextrose. Okay. So usually what you give is you give regular insulin. You can give 10 units. Okay. Plus you're gonna give D50. And you're gonna give T50, which is 50% dextrose. You're gonna give like 10 ml. Okay, so it's like an amp of D50 and 10 units of insulin. Okay, and this goes into the patient. What else can you use? And remember, insulin is gonna shift all that potassium into the cell, so you will see a drop of potassium, but that doesn't mean that you completely treat it, and we'll talk more. So you give insulin. The next option you have is sodium bicarb. Okay, sodium bicarb, and the way you order it is you just order a 1 amp of sodium bicarb, or 2 amps, depending on how severe it is. Okay, so you can give 1 amp of sodium bicarb, and again, these things you just order in the EMR, so it's pretty simple. And then what else can you do to shift the potassium into the cells? Is there one more method?
Yeah, beta-2 agonist.
Beta-2 agonist, perfect. So you've got the beta-2 agonist. So this one, it doesn't really work all that well, but you can give albuterol, and it's usually, you're giving like essentially an inhaler. It doesn't work as well as the other methods, so I usually stick with the insulin and bicarb. Okay. This is pretty much it in terms of shifting the potassium into the cells. What's nice about these is they work quickly, and you just, you see an improvement right away. Okay? Now, the other method, or the actual method, is you want to remove potassium from the body. Okay? And here there is also multiple methods. Okay? First, you can chelate the potassium. Okay, remember when we're chelating the potassium, first what do you use for chelation? You heard about Kayexalate, right? So Kayexalate is the thing to use. By the way, sometimes in the EMR you might not find it as Kayexalate. You might find the actual generic name for it, because Kayexalate is actually a trade name, even though we learned it in the books. The actual, like, it's a long name, poly something, I don't even know the name, but eventually you'll find it. If you Google it, you'll find it. If you can't find it in your EMR, just remember, this is the trade name. Okay, so what does Kayexalate do? We said it chelates the potassium, right? From where? So do you give it IV?
No, GI tract.
GI tract. So you give it PO. So it's a PO medication. Remember, it's a PO medication, and it chelates the GI tract. So what's the benefit in your mind? Like, if I give something in the GI tract and it's chelating the potassium in the GI tract, how is that helping you? So it actually, by chelating the potassium in the GI tract, it will cause a hypokalemic environment in the lumen of the GI tract, and that will promote essentially excretion of potassium into the lumen. Okay. Somebody mentioned the name of Kayexalate. It's sodium polystyrene sulfonate. Okay, you don't have to know the name. Just kind of Google it if you don't know it. But this is what it does. It actually chelates and promotes secretion of potassium into the GI tract. So it actually lowers the potassium. There's another medication that has a similar similar effect to Kayexalate. Do you guys know it? It's also a chelator. So it's sodium zirconium. Okay, so sodium zirconium. And this is another one that can be used. Some people prefer to use it, so you really want to use one of them. You can use both, but it's kind of defeats the purpose. They both do the same thing, so you can just use one of them, either Kayexalate or sodium zirconium. Okay. All right. What's next? So now you want to actually get rid of the potassium. What's another way of getting rid of the potassium?
Diuretics, loop diuretics.
Diuretics.
Furosemide.
Exactly. So we said first you want to get the potassium out in the GI tract, then you start working on the kidney. Okay. So usually furosemide is the treatment of choice here, and you can give 40. I usually give, you can give either 40 or 80 milligrams IV once. Okay. And this will promote. Now, if everything fails, what's the final measure that will work to remove the potassium from the body?
Dialysis.
Dialysis. Very simple. Dialysis. Okay. So these patients might need urgent dialysis. Okay. And dialysis is fast. It gets rid of the potassium fast, while everything is usually slow under here. But dialysis, it's slow to get to dialysis, but once you get to dialysis, it's fast. Okay? So, what's nice is most EMRs, they have a dedicated order set for hyperkalemia. So what you do is you click hyperkalemia, and then you just click all these things that you need to do, and then you just order. And then you tell the nurse, obviously, and then they will do it. Okay? Now, before we forget, let's just mention some of the etiologies of hyperkalemia, because these are the things that you need to know. Okay? So, etiologies of hyperkalemia, there is a whole bunch. There's a lot of things. But what you need to know, or quickly that comes to your mind, is first AKI. Okay, if somebody has AKI, they're at risk of hyperkalemia because their kidneys aren't working well. Okay. Next is rhabdo, or really any cell lysis. So something like rhabdo, something like STEMI, especially a large STEMI will promote essentially all the potassium inside the cells is going out. And then on the same kind of thought process, you got something called tumor lysis. Right? Tumor lysis, somebody who has lymphoma, who gets chemo, and then they get tumor lysis. And then finally, iatrogenic. So if somebody, was given a lot of potassium, kidneys is not working well, then they can get hyperkalemic. Okay, but usually, if you know these things, then I think you'll be fine to know kind of what's next. Okay. Any questions about hyperkalemia before we move to the next? Okay, so let's do hypokalemia. Okay, so hypokalemia, again, we said we're talking about, when your potassium is less than 3.5. It depends on the target. Okay, depends on the target. Usually the target is 3.5. But for somebody who you're actively diuresing, or somebody who has a CHF you're actively diuresing, or 4 if active, you will target a 4. There are some other conditions that I will target a potassium of 4. somebody who has like slow gut, slow motility, I will target a potassium of 4. Like somebody who has Ogilvy syndrome, which is pseudo obstruction, then you want to target a higher potassium, because hypokalemia can essentially can lead to slowing down of the GI, of smooth muscles, essentially. Okay. Before we start talking about treatment, let's just mention the etiologies. So what etiologies you have for hypokalemia? It's kind of, hypokalemia in by itself, you're not going to present with hypokalemia because you're well regulated. You'll always your body is well regulated, and it's not like cell lyse and you get hypokalemic. A lot of the times what's going to happen is it's going to be iatrogenic. So it's going to be, furosemide or Lasix induced, okay? So what do you do with Lasix to mitigate hypokalemia? Because Lasix is a potassium-losing diuretic, right? So you can mitigate that by giving them spironolactone, which is a potassium sparing diuretic. Okay, so this is a very common cause. You should think about it, because if somebody presents with hypokalemia, look at their home medications and check if they have any diuretics. But Lasix is the big one. Hydrochlorothiazide can cause it, so even those. The other one can be nutritional. So if somebody is like getting feeds by an NG tube or a PEG and they're not getting enough feeds, they might get hypokalemic. And then one very important one, you have to think about it. If somebody shows up with hypokalemia and you're repleting them, and they keep dipping. What is something you have to think about? Hypomagnesemia. Yeah, great. So hypomagnesemia. Who are these patients? These patients are usually alcoholics. Okay, alcoholics can present with that. So remember, hypomagnesemia will be treatment resistant hypokalemia. Okay, so this is how you know it. You check the magnesium. And so always when you have hypokalemia, the first step is check magnesium. Okay, I would say here, check magnesium right away. That would be kind of your first step. Okay, all right, cool. So the rule of thumb here, when you're repleting potassium, is every 10 milliequivalent of potassium you give the patient, it will increase the potassium levels by 0.1 milliequivalent per deciliter. Sounds good? So this is what you're going to keep in mind, is that if you give the patient 10 milliequivalent, regardless how you give it, it's going to up the potassium by 0.1. Okay? So the other question is, how can you give? So I'll give you the formulation. So usually you have either oral formulation or you have IV formulation. So let's start with the oral. Oral formulation is usually a potassium chloride. Okay? Potassium chloride comes in 20 milliequivalents KCl tablet, or 40 milliequivalents KCl tab. Okay, these are the options. The other options that you have here is, instead of the tablet, is to have a liquid, actually. So the other option would be a 20 or 40 milliequivalent KCl viscous. It's called viscous liquid, essentially. Okay. Now there are problems with each of these. Okay. Oh, finally, what's a fruit that has a lot of potassium? Banana. Yeah. So banana. So banana is. People think about that, right? For somebody hypokalemic, give it banana. It doesn't work. Doesn't work. Although I'll give you an anecdote. I had a patient the other day who I prescribed him spironolactone for ascites, and I checked a BMP on him like a week later, and his potassium was like 5 point something, like 5.1. And so I called him and I told him to. Usually, when I prescribe spironolactone alone, you give them Kayexalate, PRN, just to take if needed. So I call him up and I'm like, listen, man, your potassium is high and you should probably take the Kayexalate and come in so we can check it again. But then I started questioning him. I'm like, what's going on? Like, why is your potassium high? Are you eating something new? What's going on? He's like, oh yeah, I started eating healthy and I was eating five bananas a day. And so I was like, okay, it's probably the reason. So yeah, it can get you hyperkalemic, but it's not enough in the inpatient setting. You can't just give them a banana, okay? Let me ask you a question. What's the problem with the tablets, with the potassium tablets? Do you know?
Bioavailability? I don't know.
No, not the bioavailability. It's actually good bioavailability.
I think it can cause esophagitis.
Yeah, it can cause. So that's the second problem. The first big problem, actually, which is a big problem, it's a large tablet. It's a really large tablet. A lot of people have a tough time swallowing it. Okay, so it's a large tablet. And then problem number 2 is it can cause esophagitis. Okay, so you just have to be careful. So when you take potassium tablet, you have to tell the patient to sit up for at least 30 minutes after taking it and drink enough water so that it goes down. Otherwise, it can, if they just eat it, if they just take it when they're like laying down, it's going to sit in the esophagus and it's going to cause esophagitis, okay? The viscous does not have this problem. It's not large and it doesn't usually cause esophagitis. But what is the problem with the viscous? It's disgusting. Okay? Patients don't like it. I mean, it tastes really horrible, so they don't like to take it. But really, these are your options in terms of PO. Okay. Now, how about IV? So, when you're giving IV potassium, again, you have multiple options for IV potassium. But usually, what you're gonna use is potassium chloride. Okay. There's another formulation of potassium that you can use, which is potassium phosphate. Okay. We usually use the chloride because the phosphate is not enough, the potassium phosphate. Okay. And so usually this is the one of choice. When would you use potassium phosphate instead of potassium?
If we have a low phosphate.
Yeah, exactly. It's simple, right? So if you have low phosphate, you can use potassium phosphate. But usually you want to use the real good stuff, the potassium chloride, okay? Now, you can give 10 milliequivalent, okay? You can give 20 milliequivalent, okay? Or you can give 40 milliequivalent or 80 milliequivalent, okay? Remember, you want to increase it by 0.1. Here, what we said here, you're increasing it by 0.1 for every milliequivalent. Okay, so if you have a potassium level of like 3.2, you want to calculate how much you wanna give. Okay, so the problem with the IV, again, everything has its own problems. Okay, the problem with the IV is first you have to make sure you want to give it slowly. Okay, and so what you want to give is you want to give it at 10 milliequivalent per hour when you're giving it IV. And I'm talking here about if you're giving it peripherally. The reason I'm saying this is just the same way that potassium tablet can sit in the esophagus, cause irritation. Potassium IV can cause irritation to a lot of the blood vessels, to the blood vessel lining. So you have to give it slowly. In fact, some of your hospitals will not give more than 20 milliequivalent potassium IV through a peripheral line. So essentially, you're limited 10 to 20 milliequivalent okay? While if you want to give something more than 20 milliequivalent, like 40 or 80 milliequivalent, then this usually requires a central line. So you're not going to be able to give that much. And so if somebody has a central line, most likely they're not your patient. They're probably in the ICU. Or if you're in the ICU, it's easy. You just give it through a central line. So usually, ICU management. And the other thing you want to think about, if you want to give 40 or you want to give 80, it means the patient is pretty hypokalemic and you're trying to act fast. So a lot of the times these patients are already in the ICU. Okay. And so, in terms of scenarios, I'm just gonna give you a quick scenario. So let's say your potassium is 3.0. So a patient comes in, potassium is 3.0. What are you gonna give? How are you gonna get the potassium up? First, your target. Remember, your target is 3.5. Okay, so you have to give them at least 50 milliequivalent. Okay. So how can you do it? What do you think? IV, PO? Can you combine IV and PO?
If there's no ECG changes, I would give like 1/3 IV, 2/3 oral.
Okay, so you don't really care a lot about EKG changes, hypokalemia, unless it's very severe hypokalemia. But in general, you can combine. So I would give like 20 IV, 20 milliequivalent IV, plus I would give like 40 PO. And this whole process is gonna take about 2 hours, right? Because remember, you give the 20, 10 milliequivalent per hour, so 20 will take 2 hours, the PO is just PO, okay? Let's say the potassium is, 2.5, okay? So now you're getting pretty low. So again, here, what you can do here is you can still give the 20 IV, and then you can give 40 plus 40 PO. So 2 tablets essentially, and you want to make sure you want to separate them by 2 hours. You don't want to give them right away after each other. So you've got 2 hours for this, then you're giving the PO, then you're giving waiting 2 hours, then you're giving the PO. So this is essentially is going to take around 4 hours to complete the repletion, okay? How about if the potassium is 2.0? What do you think of this one? Here, where you start to kind of worry that patient might be unstable and might be at high risk of developing an arrhythmia. So usually, if you want to replete it quickly, okay, then you want to transfer to ICU. Consider transferring to ICU this patient, okay, because then you can give 40 IV plus 40 IV right away, and this will replete within 1 hour essentially. Because they can just give the 40 all at once in the ICU. Okay? This is pretty much it for hypokalemia. Just know your formulations and know how to replete, because that's gonna come in handy when the nurse pages you and asks you, what do you do with this? What are we gonna do with this potassium? What are we gonna do with the 2.3 or whatever? So now you know